Okay, so in anatomy, as you can see here, that there is a X-ray and there is anatomical representation. So the breast tissue consists of mainly fat, milk glands, mammary ducts, okay, the connective tissue, nerves, blood vessels, and lymph vessels. If you compare it with X-ray, this is X-ray or you call it mammogram. So this is the mammogram X-ray of the breast. You can see the skin. This white line outside the outer white line is the skin. Okay, inside you can see there are some gray structures and there are some black structures. As all of you know from my first lecture, I told you that there are different densities on X-ray, and after air, okay, outside you can see this is air. Okay, this is completely black. After that, black gray structure is the fat. So this tells you that this breast contains more fat. Okay? This is a fatty breast because it contains more grayish color. Inside also there are some white soft tissues. Okay? Uh, these are the remaining milk glands, or you can say the glandular part of the fibroglandular part of the breast. Okay. On the other hand, this X-ray, if you see this X-ray, again this is skin. Inside there is again this gray area is the. I hope you can now. I think you can see enter. Okay, so this gray area is the fatty area. Okay, this white area is the fibroglandular tissue. As compared to this, the right one and the left one, you can clearly compare both X-rays. So in this picture, you can see there is more fibroglandular tissue as compared to this. So uh, before going on to the next slides, I will tell you that with the passage of time, with aging, initially there is more fibroglandular tissue, but with aging, okay, this fibroglandular tissue is replaced by fatty tissue. So in X-rays of mammograms taken in older females, okay, it will be easier to diagnose cancer, okay, breast cancer, as compared to this X-ray. Why? The reason is that because if there is a pathology here, it will be difficult to visualize as compared to this X-ray. So we can divide the breast into four quadrants: upper outer quadrant, upper inner quadrant, lower outer quadrant, and lower inner quadrant. That the First of all, why we are dividing the breast into different quadrants? First of all, to easily appreciate and to in we can describe what is the location of the mass or any pathology. We can localize it, that explain it to some other person, that for example, there's a mass in upper outer quadrant, upper inner, or lower outer or lower inner. Okay, or this area is retroareolar region. This is the areola. Behind, behind this, if there is any mass, we can label it as a retroareolar mass. The upper outer quadrant is the most common site for breast cancer. After that, this retroareolar region, then upper inner quadrant. Okay, so according to the location, there is increase in incidence also in upper outer quadrant of breast. There are more chances of developing breast cancer, and clinically we can divide, for more specification. Clinically, we can divide the breast into clock position also. You can see they have drawn a clock: 12 o'clock, 3 o'clock, 6 o'clock, 9 o'clock. So if there is a mass here, we can label it as that there is a mass in upper inner quadrant at 1 o'clock. But this is clinically, and all of you know that ultrasound is also done. We are with the patient and we can see the location, exact location. Okay, so in X-ray we only see an image. We don't have a patient with us. So we can on ultrasound or clinically we can define further. We can tell that there is a mass in upper inner quadrant, as well as we can tell the clock position. So if there is a mass here, we can say that there is a mass in at 1 o'clock. So in ultrasound reports, you can see that they may be mentioning the clock position also. There is a mass here. They can mention like there is the mass at 3 o'clock. Mammography is the process of using X-rays to examine the human breast and is used primarily as a screening tool. The goal of mammography is the early detection of the breast cancer. So mammography, as compared to X-ray, we are using low energy X-rays. Number one, what is the advantage of this using low energy X-rays? The most important advantage of this is that we get good soft tissue contrast images. Because we are using low energy X-rays, and we all know that in there is mainly soft tissues. There is no bony tissue, so we don't need too much penetration. For that reason, because whenever we are using high energy X-rays, we need the purpose of using high energy X-rays is to penetrate more into the tissues, because the tissues are thick, so we have to penetrate more. But in mammography, we don't need to penetrate more because there are only soft tissues. So we can use low energy X-rays, okay, and we will get a good soft tissue. And also the other advantage of using low energy X-rays is that there because breast is sensitive for radiation, breast tissue is sensitive for radiation, so we are giving low energy X-rays, so there are less chances of developing development of breast cancer due to imaging. The goal of mammography is early detection of breast cancer. Basically, the main purpose of the mammography is screening. It is used as a screen for early detection of breast cancer. Before it is more pronounced clinically, we can detect it on mammogram. Because when it is evident clinically, then most of the time it is very late. So if we are performing mammography, we can detect early stage breast cancer. Uh, for that reason, there is estimated reduction in mortality up to 35%. There is decreased mortality in cases of breast cancer up to 25%, and 10% false positive. So sometimes we see a mass, we think that this is a breast cancer, but it turned out to be a benign pathology. So there are chances of 10% false positive. But still, there is a lot of advantage of doing mammography. So what are the indications for a mammography? In which patients we are going to perform mammography? Because we cannot perform mammography in every patient. I will explain it to you why we cannot perform. Uh, so first of all, for screening asymptomatic women aged 50 years and over. So any woman who is symptomatic or asymptomatic, if she is more than 50 years, so we will perform in every woman. We have to perform screening for breast cancer. So, and females who are 35 years and above, and they are asymptomatic, but they have a high risk of developing breast cancer. Who are these women? Number one, who has first degree relatives in family who has breast cancer. Like her mother had breast cancer, her sister had breast cancer. So if there is any history, we have to start examining or start mammography as early as 25 years of age, because there is increased incidence. Women with histological risk factors found at previous surgery. For example, previous some biopsy has been done and it didn't show cancer cells, but it showed atypical hyperplasia. There are atypical cells present. Okay. So again, there is increased incidence of developing breast cancer in future if it has atypical ductal hyperplasia on biopsy, or there is inherited BRCA1, BRCA2 mutation genes. More than 50% developing breast cancer by age of 50. So basically, are for screening purpose. So whenever we are performing mammogram in asymptomatic women, this is so we have to perform screening in every woman who is above years and all the women who has high risk of developing breast cancer. We will start performing the mammogram at least once a year after 35 years. Investigation of symptomatic women aged 35 years and over with a breast lump or other clinical evidence of breast cancer. So, if a female coming with symptom like there is a breast lump, there is blood in nipple discharge, or any symptom related to breast cancer, if a patient complains of that, okay, we have to perform mammogram after 35, still 35 years of age. I will discuss why 35 years of age. Surveillance of the breast following local excision of investigation of suspicious breast lump. Okay, so there are different views, just like in chest, we perform there are some standard views, there are some supplement. What do we mean by standard views? Standard views, as just like in chest, we perform chest X-ray, posterior, anterior view. All of you remember, PA means the projection of X-ray beam. The X-ray beam is coming from the back of the patient. That's why we are saying posterior, and the X-ray film is anterior. So the X-ray beam is projecting from posterior to anterior. That's why it is called chest X-ray PA. Likewise, in mammography, we perform two standard views. Number one, mediolateral oblique view, and the other one is called cranial. Okay, because if we see a mass uh, on mediolateral oblique, it is somewhat same like lateral view. But the only difference is that we are giving some angulation to the X-ray tube. That's why it is called oblique. Otherwise, it is same like lateral view. So if we see a mass, if we cannot comment on whether it is medial or lateral, we can only comment on superior or inferior. So that's why we need another view, which is called cranial caudal view. If we see a mass from above downwards, then we can comment whether the mass is medial or lateral. I will show you. Supplementary views means all of you can understand from the word supplement. They are additional views or additive views which help us in making our diagnosis. So number one, lateral. This is a true lateral view, lateromedial or mediolateral. Extended craniocaudal, medially or laterally related. So this is a same like craniocaudal view, but we ask the patient to move medially or laterally. So sometimes we need to see the axillary tissue, because in craniocaudal view, if you don't get axillary tissue, sometimes the mass is extending into the axilla. Okay, so if you want to see that mass, we can perform extended craniocaudal. We ask the patient to move, and then we will compress the breast tissue. Then we will be able to visualize the axillary tissue. Magnification. If we move the uh, subject, uh, if we move the X-ray film away from the subject, okay, then we can magnify the image. Okay, and this magnification is done to see micro calcification, small calcification, very small specks of calcifications in the mass. We use this method. Localized compression may be combined with magnification. We can, instead of giving compression to the whole breast, we can compress a specific area where we are suspecting mass. Cleavage value view, if we take view of both breasts at the same time in craniocaudal view, okay, then this is called cleavage value view. Because sometimes the mass may be extending towards the other breast from the medial aspect. So in that case, we can perform cleavage. These are the diagrammatic presentations how the X-ray is done, and these are the mammograms. How can you recognize that this is a craniocaudal view and this is a this is a mediolateral oblique view and this is a craniocaudal view? First of all, if you look at this image, the X-ray radiation is coming from medial aspect, and you can see this is the X-ray film. Okay, so this is mediolateral projection, and I told you we are giving angulation. That's why it is called mediolateral oblique view. And in this picture, you can see they have given compression to the breast, and the X-ray tube must be above, and the X-ray film will be below. So that's why it is called craniocaudal view. And in every mammogram machine, there is a compression device. Why we are giving compression? First of all, it will reduce the dose, X-ray dose to the patient, because the egg tissue is evenly spread. Okay, so the patient will receive less radiation dose, because if the tissue is more packed together, okay, we have to give more X-ray radiation to get a good image. Number two, the reason is that if we compress the breast tissue, other advantage is that we can disperse the fibroglandular tissue, and there are less chances of overlapping of fibroglandular tissue. So fibroglandular tissue appears white. If we do not compress it, it will come close to each other and it will give you a more white image, and you will not view the mass. It will be difficult to visualize the mass. This is the reason why we are giving compression. First of all, to reduce the dose, and the second is we can get a good image in which we can recognize different tumors. So this is a mediolateral oblique view. How can we recognize? Because when we are giving compression from laterally, we can compress the pectoralis major muscle. But in craniocaudal view, we cannot compress the pectoralis major muscle. That's why whenever we see pectoralis, this is pectoralis major muscle. You can see there is increase in density here at the back of the breast tissue. You can see here. So this is the pectoralis major muscle. So this is how we can recognize the mediolateral oblique view. Otherwise, if we don't see this, it can be a craniocaudal view also. So from this we can recognize. So this is the areolar region. Okay, you can see this is the nipple area. We draw a line to the orientation of the breast, to the chest wall, okay. And any mass which is above this line, we call it. We can label it in that this mass is in the upper quadrant. If the mass is below this line, we can say the mass is in the lower quadrant. So on lateral view, we can only confirm that the mass is in the upper quadrant or lower quadrant. Like if you see this image, we draw a line perpendicular or parallel to the orientation of the breast, the chest wall, and if the mass is above, we can say upper quadrant or lower quadrant. Now here we are seeing mass from above. If the mass, for example, this is the craniocaudal view. If there is a mass here, this is the right breast. So if we see a mass here, so this is the right breast. So that means the mass is in the outer quadrant. Or if the mass is here, we can say the mass is in inner quadrant. We draw a same line from the nipple area to the chest wall. And if the mass is, if this is the right breast, so if the mass is present here, it will be in the outer quadrant. Or if the mass is present here, we can say label it as the mass is in the inner quadrant. So this is how we from a mammogram, we need both medial lateral oblique view and cranial caudal view to explain whether the mass is in the upper quadrant, lower quadrant, outer quadrant, or inner quadrant. This is the reason why we are performing two views. These are the standard we have to perform in any case. So this is the localized compression with magnification. You can see the mass clearly, more clearly, and if there are any microcalcification, we can also visualize it. So this is the same diagrammatic presentation which I told you that mediolateral oblique view there is 40 to 60 degree. As I have explained earlier, that the dark areas are normal, fatty breast tissue, lighter areas are denser tissue. The whitest area is the most dense, indicating a tumor. So the black areas are the fatty tissue, the white lines and the white tissue. They are mostly the glandular tissue, fibroglandular tissue, and fibrous tissue basically supporting tissue. Glands are the milk glands. So if you see a more white tissue, then this is indicated. Or on X-ray, we label it as radio opaque mass. This is the X-ray, so we label it as radio opaque. This is the mediolateral oblique tissue. You can see the axillary tissue. This is the breast tissue. You can see the black areas are the fatty areas. Fatty areas. This is the skin white line of the skin. Okay, and the white areas inside the breast are due to the tissue. This which, these four pictures are showing different uh, basically the evolution of breast from fibroglandular. This is this must be a young patient with more fibroglandular tissue. Now here there is diffuse fibroglandular tissue. Here there is localized in a localized area. There is more fibroglandular tissue. Here there is scattered fibroglandular tissue, and here it is fatty breast. A completely fatty breast, there is more fatty tissue as compared to this breast and this. So with the passage of time, the fibroglandular tissue is replaced by fatty tissue. Okay. So now we will discuss some breast lesions. There in breast, there may be radiolucent lesions, there may be radiopaque, or there may be mixed density lesions. Mixed density means some areas may be radiopaque, some areas may be radiolucent. So radiolucent masses, as we have already discussed, that fat appears radiolucent on X-ray. Okay, so that's why fat-containing tumors or fat-containing masses, they will appear radiolucent, like lipoma. If there is a lipoma, uh, lipoma is a soft tissue. Okay, if it is present in the breast, it will appear as radiolucent. Rectocele, oil cysts, will also appear radiolucent. Ulcers can be recognized with the mural curvilinear calcification around the mass. Inside, it will be radiolucent. Radiopaque masses may be benign or may be malignant. Benign may be cyst, fibroadenoma, abscess, phyllodes, lymph node. Fibroadenomas are the most common benign tumors of breast, especially at a young age. This is the most common. Phyllodes tumor is somewhat like giant fibroadenoma with mixed appearance. It doesn't have a typical appearance, but so lymph nodes, malignant carcinoma, lymphoma. So whenever we see a mass, radiopaque mass, how we are going to describe it? We describe its contour, shape, capsule, halo sign. I will show you what is halocine. Halocine is that there is a radiopaque mass surrounding the mass. There is a radiolucent line. This radiolucent line indicates that it is a benign mass. The growth is benign because it is not infiltrating. Surrounding it, there is a surrounding a benign mass. There is a vacuum between the normal tissue and the benign tumor tissue. There is a gap. So that gap is represented by a radiolucent line that is called halocine, and this is indicative of benign growth, benign mass. So, and we can also describe whether the mass is well defined, ill defined. So this is about the radiopaque mass. Then there are some mixed density masses, fibroadenal lipoma, or it is called hematoma. May appear, some areas may appear radiolucent, and some areas may appear radiopaque. A mammography assisted layer as a round, oval, or lobulated mass with circumscribed margins. In my first lecture, I told you from black to white, and there are different densities. And first of all, there is air, then there is fat, but after fat, there is soft tissue. So the density of soft tissues is white. Uh, Soft white, or you can say gray, but light gray. Okay. But the fluid density, fluid is more brighter than the soft. So it will appear white, uh, and you can see if it is a cyst, it will be well defined, maybe round, maybe oval, maybe there is lobulations, and there will be circumferent well defined margin. This cannot be reliably diagnosed with mammography alone. Further evaluation with spot compaction, mammography, and ultrasound. Whenever we are suspecting any mass, we always perform ultrasound with it, because ultrasound can easily differentiate a cystic and a solid mass. There is no need for further views or some suspecting. We can easily differentiate it. So in this picture, you can see there is a very well-defined oval mass in the outer quadrant of the test. It turned out to be a simple cyst when we performed the cyst. Why it is simple cyst? Because it is well-defined, okay, and it is anechoic. There are no septations. There is no thick wall. There are no echoes inside. So these are all definition of simple. So sometimes cyst may be complex also. Cases of abscess, hemorrhage, or malignancy. All the features which I told you as no or absent, they may be seen in abscess, hemorrhage, or there are, for example, there are septations, okay, or sometimes you can see echoes inside the cell. They are all indicative of cyst. This is a mammogram of uh, lipoma. Lipoma, because it is a radiolucent, it is well defined capsulated mass. Okay. And you can see the breast is very dense, so there is more fibroblasts. This is oil cyst. Okay, how can we recognize this is an oil cyst? It's wall calcification, curvilinear wall calcification. Okay, otherwise, it will be very difficult to visualize the oil cyst. So this is fibroadenolipoma or hematoma. You can clearly visualize the benign mass. How can we tell with the help of this halocine? This is the radiolucent line which is surrounding the mass. This is indicative of the benign nature of the mass. And inside the mass, there are some areas which are radiopaque. There are some areas which are radiolucent. The mixed density mass. So this mass contains fibrous gland, fibrous tissue, glandular tissue, as well as the fatty tissue. very sensitive lesion. This is a very well defined benign oval shaped nodule, and really visualize this is well defined, and to some extent the halo sign may be complete or may be incomplete also. So it is not necessary that you whenever you see a halo, it will be very well defined and it will be complete halo sign. So you can see in some areas this you cannot see the halo sign here, but you can see the halo sign. Like here also we can see the halo sign, this white, this radiolucent line. So the nodule is well circumscribed and denotes beta part. Second thing, after describing the mass, we look for calcifications. Calcifications are very important for description of mass. Why? The reason is that because we, if the calcifications are appearing, if we see a mass, radiopaque mass, and there are very small, tiny specks of calcification inside the mass, it raises the suspicion of malignancy. Okay, otherwise, microcalcifications are that means they are very tiny, fine specks of calcification. They are really non-cancerous, but can sometimes be a sign of cancer. So, especially in ill-defined lesion, and there are tiny specks of calcification, there are very high chances of malignancy. And macro calcifications, from macro you can understand the calcification large. So they are large white dots, almost always non-cancerous and require no further follow-up. So if we see a mass with a big calcification, there are increased chances of that the tumor is benign. So especially in cases of fibroadenoma, they show calcifications, especially popcorn typical presentation, popcorn-like calcifications. They are benign tumors, and they require we can perform biopsy from our diagnosis. So these are big calcifications. They have round calcification with central lucency. They are indicative that these are vascular calcifications and they are benign. And you can see here there's a radiopaque mass with central microcalcification. So it may be cancerous. We have to perform biopsy in this case or in this patient. You can clearly visualize there are very small, tiny specks of calcium. These are called microcalcifications. These are called macrocalcifications. Again, this is macrocalcification, and you can see clearly visualize this is popcorn-like appearance. Okay, this is indicative of fibroadenoma. You can see there is a radiopaque mass with a large calcification. Small calcifications are also present. Surrounding the mass, there is radiolucent line. This is halo sign, okay. And so this is a benign mass. And here in the next picture, we can say uh, uh, there are microcalcifications scattered in an area. Okay, it raises the suspicion of malignancy. Can be benign also. So we have to perform a biopsy in this area because there is no radiopaque mass. There is no there is no mass here. There is no radiopaque mass. We can see only thing we can see is the microcalcification. This is the suspicion of malignancy. We have to perform biopsy. So, is sonography or ultrasound is performed primarily to differentiate from solid lesion. It is not diagnostic. And the biggest advantage of performing ultrasound is that along with ultrasound, we can perform biopsy with the help of ultrasound. Diagnosis of breast cancer depends upon the examination of tissue or cells. Safest course of biopsy, examination of we can take biopsy of all suspicious masses on examination or and of suspicious mammography. So, in addition to mammography or MRI, we always perform ultrasound along with the mammogram and MRI. Ultrasound is performed in all symptomatic breast lumps in women aged less than 35 years. More than 35 years, uh, we can perform mammogram also. But in less than 35 years of age, because there is more fibroglandular tissue and mammogram will not be very helpful, and we don't want to give radiation to a young patient. So that's why in women who are less than 35 years of age, we then perform breast lumps developing during pregnancy or assessment of mammographic abnormalities, test of MRI or CT mammography, connected lesions, clinical breast mass with negative mammograms, or if the breast is inflamed, if there is inflammation of the breast, for example, there is an abscess or there is diffuse inflammation, in that scenario, we cannot perform mammography. Why? Because we are giving compression. If we give compression to an inflamed breast, it will cause severe pain as well as it can cause uh, patient. We will not be able to perform mammogram. So in this cases again we will perform the ultrasound. In case of augmented breast, if there is a breast implant, a silicone breast implant, again in those cases we do not perform mammogram. We can ultrasound or MRI. Breast lump in a male, guidance of needle biopsy or localization. As I have told you, the best modality will be the mass and we can perform the biopsy. Follow-up of breast cancer treated with chemotherapy. This is the ultrasound of the breast. These these are not cysts, not myths. These are ribs. Of the ribs, this is the pectoralis major muscle, and this heterogeneous tissue is some areas are hypoechoic, some are hyperechoic. Uh, Fibroglandular tissue, fatty tissue. This is the breast tissue, and behind the breast tissue there is this hypoechoic area with linear lines. This is the pectoralis major muscle, and this is the skin of the breast. The ultrasound on ultrasound, there the mass may be all. If it is benign, sometimes it may be cystic. So cystic, we can separate cystic. It will be anechoic. And if it is a radio fake mass on mammogram, that means there is maybe benign or malignant. In those cases, if it is on ultrasound, if it is purely and intensely hyperechoic, it is hyperechoic because of the reason of macrocalcium. It may be hyperechoic. And if it is malignant, so in malignant, as we have discussed, there if there are calcification may be micro, and they will not create a hyperechoic. It will not give appearance of a hyperechoic. So basically, both benign and malignant masses are hypoechoic, like here it is hypoechoic. But benign masses, because of macrocalcification, they may appear uh, hyper. And in malignancy, most of the time they are mainly hypoechoic. Very important feature for on ultrasound for benign masses is that they are wider than broad. They are of elliptical shape on ultrasound, and as compared to malignancy, they are more taller and wide. Benign masses may show lobulations, but lobulations will be few, 3 to 5 lobulations. But in case of malignancy, there will be micro lobulations. Yani, there are multiple lobulations, more than 5. Sometimes you can see the duct extension. You can see a dilated duct, and there is extension of tumor inside the duct, so that is indicative of malignancy. On ultrasound in a benign mass, sometimes we can capsule. If it is well defined, there is a capsule. If it is a benign mass, like here, this is a lipoma, and you can clearly see the capsule of mass. The ecogenicity of the mass is like somewhat same like breast tissue because of the fatty content, both and uh, the fat content. So they are appearing of same ecogenicity. It is a well-defined mass with a capsule, well-defined capsule, the same like the breast tissue. On mammogram, you can clearly visualize the white line is the capsule of the mass, and inside the density is same like the breast tissue resolution. And this is a malignant mass. How? Why this is a malignant mass? First of all, you see the radiopaque mass, which is ill-defined, and most importantly, it is causing architectural distortion. What is the meaning of architectural distortion? Normally, all the fibrous tissue is converging onto the areolar region. So, but here the fibrous tissue is going in different direction because of this tumor. Tumor has caused the fibrous tissue of the breast go in different directions because it is engulfing or it is stretching the normal breast tissue. So it has caused the architectural distortion. This is a very important feature for malignant masses or in the description of malignant masses. Okay, so we can see there is a radio opaque mass with ill-defined margins, fitted margins. You can see these are appearing as spicules, okay, and there is surrounding architecture. This is the how we are going to describe. Okay, and there are few areas of microcalcification also. Tiny specks of microcalcification, and on ultrasound you can see there is a hypoepic mass, and you can see there are micro lobulations inside. There are many lobulations inside, and you can see this is smaller and wide. This is a very good example of a malignant mass, and you can see the margins are not clearly defined, not well defined. They are there is extension of the mass in the surrounding. So breast mass may be a cyst. We have discussed that cysts appear um, anechoic. There will be a thin echogenic capsule enhanced through transmission and thin edge shadows. Cyst with anechoic center. Okay, this is called enhanced transmission of the ultrasound waves. And this is called posterior acoustic enhancement because there is enhancement posteriorly of the sound waves. This is called enhancement as shadows, and this is anechoic with thin capsule. And at the same time, when we are performing, we fine needle aspiration, and we can confirm our diagnosis. Simple cyst. Um, Breast masses may be complex also, and sometimes we can see different level internal issues with debris level, septation, wall thickening, and causes may be infection, pregnancy. This mass can be an abscess. Mass can be a tumor also, because you can see here there's uh, dependent portion. There is a soft tissue area, and on the non-dependent area also there are nodules. Can be a malignancy also. We have to perform biopsy in this case or assess clinically. It may be there may be signs of abscess clinically. You can see the redness. You can patient may become with fever. This may be a hemorrhagic cyst or maybe an abscess also. no chances of there are echoes which are seen on which on dynamic ultrasound you can see there may be palpable masses of the breast according to age. So if the patient is young, between 25 years of age, the most of the palpable lumps may be fibroadenoma, and they will be fine, round, mobile, and non-tender. And between 25 to 50 years of age, the most common cause of palpable mass is cyst, then fibrocystic changes, and then cancer. Cyst, it may be usually soft, firm, round, mobile, tender. Fibrocystic changes, you will see nodular appearance of the breast, a rope-like appearance. Cancer may be irregular, stellate, firm, not clearly delineated from surrounding tissue. Over 50 years of age, it is considered cancer until proven otherwise. Move out to be a benign mass on biopsy, but we will consider it as malignancy until biopsy does not show benign mass. So, in pregnancy lactation, patient may develop lactating edema, cysts, uh, and mastitis. This is the ultrasound pictures of benign masses. You see, this is a well defined lobulated mass. Are the lobulations. I told you if there are few lobulations, it is indicative of benign mass. It is wider and tall. Again, this is a diagnostic feature of a benign mass on ultrasound. And this is again a benign mass. You can see well defined, almost same wider, tall. It is same size because it is round. Okay. And but diagnostic feature is that it is well defined. You can see the capsule also, so it is likely a benign mass. Again, well defined, lobulated, well defined, wider than tall. It is a benign mass. So, tissue diagnosis obtained without surgery can perform with the help of ultrasound. Benign one procedure, no surgery every time. Malignant one minimal invasive procedure can shift the patient to OR diagnosis. So, risk needle biopsy, there are less chances of bleeding because there is no major blood vessel in the breast, and any bleeding usually controls. Uh, or to reduce the chances of infection, we can use sterilized technique. Now, last we discussed the MRI. MRI has high sensitivity breast cancer, and the main purpose of performing MRI is for staging multiple or colorectal cancers, scar versus recurrence. It is the best tool to differentiate between a scar tissue and recurrence. What is the meaning of this? That if there is recurrence, we remove the tumor breast cancer, and there is recurrence, we cannot differentiate on mammogram or ultrasound between fibrous tissue, which is a scar tissue, and the recurrence. Only tool which we can use is MRI. MRI can easily differentiate scar and recurrence with the help of MRI images, MRI images, and help of contrast. Between contrast, there will be contrast enhancement in recurrence, but there will be no contrast enhancement in scar. And on T2 weighted images, recurrence area will be hyper intense, but the scar area will be hypo intense. The optimum method for imaging breast implants and detecting implant leakage or preoperative evaluation and detection recurrence after. So you can see here that there is recurrence after the surgery. This area is appearing like there is a radiopaque mass with artificial distortion, but this is very difficult to assess on image. So it's difficult to assess whether this is a fibrous tissue with a post-surgical change or this is there is some recurrence because we cannot tell because the Surgical changes will also appear same like this. There will be soft mass with the architectural resolution. But on MRI with contrast, we clearly visualize that there is enhancement here, which is suggestive of this small mass. Breast cancer symptoms, first of all, in last we will discuss the radiographic features of breast cancer. Clinically, patient will present with pains, lump or swelling, ill-defined. There may be nipple retraction or nipple discharge. There may be swelling because of the axillary lymph node. So, in mammography, what do we see? We see a radiopaque mass in mixed densities. The margin will be stimulated. There will be microcalcification. The mass will be ill-defined. On ultrasound, mass will be lightweight. Lesions also ultrasound mass will be taller than wide. You can see the depth and microlobulation. Here, you can clearly visualize this is a mammographic image, this is an ultrasound image. And on mammography, you can see there is a radiopaque mass with speculated margins. There is surrounding architectural distortion also. And there are few macrocalcifications, but these macrocalcifications may be old and there is superimposed malignancy over the macrocalcifications. So other features are very typical for malignancy. On ultrasound also, we visualize the margins are not clear. There is extension of the tumor in the adjacent soft tissue, and the mass is taller than wide. And again, you can see the macrocalcification. Macrocalcification is diagnostic for benign mass, but in this case, this calcification may be old and there is superimposed malignancy. So that's why this you can see macrocalcification. Otherwise, there are no. There is macrocalcification is not a feature of malignancy. After diagnosis of malignancy, how we proceed? All of you know that first of all we will assess the lymph nodes. After lymph, we have to see the metastasis. For the most common site for metastasis is the lungs, liver, bones, and then so these are the four important sites of metastasis. So for assessment of the lungs, we can perform chest X-ray or CT scan. If there is high and also or along with CT scan of the liver and brain if there are chances the patient is complaining of some symptoms involving the brain. We can also and for bone on the bone scan. Bone scan is a radionuclide scan of the bone because I told you the multiplicity of the lesion. We always perform radionuclide scan. This picture is again showing you the incidence of cancer according to location. 45% of the tumors, breast tumors, occurs in the upper outer quadrant. 25% of occurs in the retro-areolar region, and 50% occurs in the upper inner quadrant. Then the lower outer, and then the this X-ray is showing you multiple large nodules, variable sizes, giving cannonball appearance, the typical appearance of cannonball appearance. There are multiple soft densities in both sides of the lung, the typical presentation of lung metastasis. So basically, this is just to tell you that main purpose of mammography. Mammography is a very important. of the breast. Screening mammography advised with no complaints or symptoms of the breast cancer. The goal of screening mammography is to detect breast cancer when it is still too small. Recommends that women begin receiving screening mammography. The message also uh, is like mammographic screening is key to early detection of the breast cancer. Women in their 40s should get mammograms every 1 to 2 years. At age mammography should be. Thank you. Do you have any questions? Yes.